Thank you for joining us today, Dr. White.
Yeah, it's my pleasure. I think I was supposed to be sharing this with a couple of others, but I think it's just me.
Yeah, we'll see.
Yeah. Okay. Who? Oh, 100 participants on the call. That's impressive.
In both right and left.
All right. So I have just a little bit of a kind of talk about, neurovascular emergencies, especially interventional emergencies that I was going to give to everyone. I'll introduce myself. My name's Tim White. I'm one of the neurosurgeons. I practice at North Shore University Hospital and Lenox Hill Hospital. I kind of see patients in both locations. And my training is in cerebrovascular neurosurgery. So I do both open cerebrovascular neurosurgery and endovascular neurosurgery. And I did a fellowship in endovascular neurosurgery, which is endovascular, literally endo is in vascular vessels, meaning procedures where we're going through the blood vessels and take care of different things with blood vessels. That includes things like strokes and aneurysms. And I'm sure you guys have talked a little bit about these things already. In the past couple of sessions. But I'm just going to focus on some of the kind of neurovascular emergencies we see, a little bit more focused on the endovascular and interventional side of things. And I'm sure you guys are getting plenty of exposure to the kind of surgical side of things. So I hope this kind of helps balance things out a little bit. Let me share my screen. Okay. I hope this is what everyone was looking for and everybody's interested in. If this is not, I have about 100 other talks I could present at any given time. So if you want a different topic, anybody can feel free to speak up and reach out. And if any questions occur throughout the talk, feel free to speak up, and I'm happy to answer them and address them. So these are some neurovascular emergencies that we see. The biggest neurovascular emergency we see, obviously, is stroke. And when we talk about stroke, there's two different types of stroke. There's ischemic stroke, which means lack of blood supply, and there's hemorrhagic stroke, which means bleeding into the brain. And we'll kind of get into that a little bit. But these are really the big common kind of neurovascular emergencies that we'll see. And by emergencies, I mean these are the things we treat absolutely emergently. There's a whole other field of what we do on the surgical side that don't include emergencies, things we treat in more elective fashion, which I can talk about a little bit later. But I just wanted to focus on this because I think that, from the urgent emergent perspectives, these are some of the most interesting things, basically. As I mentioned, the number one thing we talk about and think about is ischemic stroke. We see patients with trauma to the blood vessels, the brain and spine. We see patients with hemorrhagic stroke. Hemorrhagic stroke is, again, bleeding into the brain. Epistaxis, which just means nosebleed. Yep, we do treat patients with nosebleed. We go in and we block off the blood vessels that are bleeding, usually in kind of extreme cases. We see patients with what are called fistulas or arteriovenous malformations, which are basically abnormal connections in the blood vessels from the arteries to the veins. We treat patients with strokes in their eye, and we treat patients with hematomas, subdural hematomas. So just to get a sense of kind of what we do, this was a case we treated a few years ago. This was a patient who, as you can see, obviously had injury to the eye. That's a scissor in his eye. And this is what his angiogram looked like. So the reason why we did an angiogram is because the carotid artery runs into the brain just behind the eye and the apex of the orbit. And in fact, if we were to look at the eye, this is what's called a diagnostic angiogram. So what's happening here is we're taking x-rays of somebody's head, and then we're injecting contrast dye, which is what's called radiopaque, meaning that on an x-ray it looks black. And so we're injecting contrast dye into this person's blood vessel, and we're seeing extravasation from the blood vessel. And extravasation means literally the person's bleeding from the scissor puncture of the carotid artery into their eye. So when the scissors came out, there was just blood pulsing out of this person's eye socket, essentially. And so you can imagine this is not something that you could easily treat with any sort of open surgical procedure, but it's something that we can certainly treat by going in through the blood vessels. So this is his carotid artery here, going up through the blood vessels into the point that's bleeding and basically blocking it off. So this is the kind of stuff we can do in the angiography suite from the interventional perspective to take care of some of these patients sometimes. That being said, that's not obviously the most common thing. The most common things we see are ischemic and hemorrhagic stroke. Little case example here. This was a 77-year-old male with a right internal carotid artery occlusion who came in. His what called NIH stroke scale was 17, which means that the NIH stroke scale is a scoring system we use to grade the severity of someone's stroke. So 0 is walking around, no symptoms at all. And then you get points depending upon how severe your neurological compromise is. So if you have weakness, you get up to 4 points in one of the arms or one of the legs. If you can't produce speech and produce words, you can get 2 to 3 points from that. So his stroke scale was 17. And the reason for it being 17 is because he had significant weakness on the left side of his body, because the right side of the brain controls the left side of the body. And he was not able to lift his left arm up, lift his left leg up. He had some slurring of his speech. He had facial weakness, all of these things contributing to him having what's called a relatively high stroke scale. The interesting thing here is he was normal 18 hours prior. But had we not been able to do anything for this patient, he would have been probably bedbound for the rest of his life. This is his non-contrast CT. Can you guys see my pointer? Here, I got it.
Yep.
This is his non-contrast CT head. These are his eyes. So a CAT scan of the head uses radiation and X-rays, basically sends photons through somebody's skull to create a picture and a reconstructed picture. So things that are dense look very bright on a CAT scan. So bones look very bright, and then air looks dark and black. So what you can see here is these are his eyes. So this is the front of his head. This is the back of his head. This is the right side. This is the left side. And he has a little bit of blockage. I mean, not a little bit. He has got a blockage of one of the major arteries to his brain. So when we talk about CAT scans, we always look for symmetry. So you see this vessel loop coming up right here. The reason why we can see the blood vessels is because we gave a dye that lights them up. And that same turn is not present here. In fact, you see this straight line right here I'm tracing out. You see none of that over here. And the reason for that is because there's a blockage of this artery on the right side. This is the right side of his head. And that blockage is what's causing his symptoms. So why do we care about patients who are having stroke? Why do we care about, this 77-year-old who's having this stroke? And ultimately it comes down to, the reason for that is time is brain, because stroke is one of the leading causes of death and disability worldwide. It's the fifth leading cause of death and disability in the United States. Yearly, it takes a toll of about $56 billion per year on the United States economy. That's basically ischemic stroke alone. There are about 800,000 strokes per year in the US. The same number as there are heart attacks. It's the fifth leading cause of death in the United States and one of the leading causes of disability in the United States. On average, every 40 seconds, somebody's having a stroke in the US. About 2 million brain cells die for each minute that a large blood vessel is occluded and isn't opened up. And as I mentioned, stroke costs about $53 billion annually in the United States. So this is ischemic stroke. It matters a lot. It can be very problematic for patients, obviously. But as I said, there are different types of stroke. There's obviously ischemic stroke. And so this is a picture of an ischemic stroke. So in ischemic stroke, what happens is there's a blockage of the artery into the brain. So again, this is an angiogram here. You can see these kind of circles. This is the person's eye sockets. This is where their eyes would sit. We're injecting here the right carotid artery. Again, the dark stuff is the dye in the blood vessel. you can see the dye coming up into the head, and then it stops. You see there's a straight line that stops right there, right where my red arrow is. That's a blockage of the blood vessel in the brain. And that blockage causes lack of oxygen to go to the brain, and then it causes basically death of the cells in the brain. There are about 87% of strokes are ischemic stroke. The other type of stroke is a hemorrhagic stroke and makes up those other 15-ish% essentially. The most devastating stroke are strokes caused by large vessel occlusions. So you can have a blockage in any artery in the brain, small blood vessels, large blood vessels, but certainly the most severe is the one that is caused by large vessel occlusions, essentially. The other types of stroke are hemorrhagic strokes, again, making up about 15% of all the strokes, And so again, what you see here are non-contrast CAT scans of people's brains. Again, this is the front of their head. This is the back of their head. This is the right side. This is the left side. And you can see their skull is bright because it's dense. And then we see, when we look at a CAT scan, as I said earlier, we look for symmetry. So on the left side here, this is the normal side, normal brain. And then on the right side, you see this large white thing. And here, you see a lot of white in this star-shaped pattern around the base of the brain. So this color white on a CAT scan is hemorrhage. So you can see this hemorrhage on these two CAT scans. This is what's called a subarachnoid hemorrhage. This is called an intraparenchymal hemorrhage. An intraparenchymal hemorrhage basically is thought to occur when a blood vessel kind of ruptures and causes leaking and bleeding into the brain tissue, as opposed to a subarachnoid hemorrhage, which causes bleeding into the base of the brain and base of the skull, essentially. And that can be life-threatening. In fact, about 20 to 30 patients with subarachnoid hemorrhage die. 10 to 15% don't even make it to the hospital, and then another 10 to 15% of patients pass away even if they make it to the hospital. It can be very fatal and cause major problems. So that's why we care about these things and why we manage them. The other type of stroke is, you guys may have heard of a transient ischemic attack, and that's basically what we call a minor stroke. But why that's relevant is because 7% of patients with one of these strokes will have a real stroke in 90 days. So these patients need to be seen and they need to be taken care of. Some common stroke symptoms, just to review, it matters where you're having the stroke. If you're having the stroke on the right side, then you're going to have left-sided weakness. If you're having the stroke on the left side, then you're going to have right-sided weakness and speech problems. And then if you're having the stroke in the brainstem, you can have all different types of problems. You can have speech problems, swallowing problems, eye movement problems, nausea, vomiting, headache, vertigo, as opposed to bleeding in the brain. In bleeding in the brain, the most common symptoms are headache, nausea, vomiting, and then sometimes you get weakness as well, depending upon where the bleeding is. And why it matters is because if patients are coming in with an ischemic stroke, we can often do things to help them. And what we can do is we actually go into the blood vessels in the brain and we try and take the clot out, and we physically remove the clot. And what's interesting is, when this first started, this only came into standard medical practice 10 years ago. So prior to 2015, people were not doing this routinely, where you take a catheter up into someone's head and you go and try and pull the clot out. There were a number of 5 clinical trials in 2015 that essentially changed this, and that allowed us to basically start treating these patients more aggressively. And it's now to the point where you can treat many, many different patients. We treat patients with large vessel occlusions, medium vessel occlusions, children we've treated before, large strokes, small strokes, all different kinds. When can we treat these patients? We can treat them up to 24 hours. And this is a big change. This really just happened in the last few years. But we're starting to treat patients later and later out. And now it's standard of care that as long as the patient's coming in within 24 hours, we'll oftentimes offer them treatment for their stroke potentially. So what does that treatment look like? I'm just going to skip ahead a little bit. This is what that looks like. This was that patient that I just showed you. So what you hear now is us, what you see now here is us actually doing an angiogram. So this is what it looks like when you do an angiogram. This is the faint outline of the catheter, this white line here. And then this is the blood vessel here. You can see the blood vessel then continuing up. When we do an angiogram, we take x-rays. We take x-rays from the front to the back and the side to the side. So when we do angiography, we see two different pictures, one that's front back, one that's side side. So this picture is front back, this picture is side side. And this is us. What we have to do is go all the way from the artery in the leg or the artery in the wrist and take it up small tubes into the artery in the brain to try and take that blood clot out. So this is one of those tubes here. What you can see now here is this is what we see when we do the angiogram. Again, this is the image. This is, sorry, let me put my laser pointer back on. This is the image of the front back. This is the image from the side to the side. And what you can see is when we inject the dye, you can see all these tiny little blood vessels lighting up. This little ring right here, this is the tip of the catheter. Actually, this is where we're injecting the dye from. And again, what you can see is coming up into the head, this blood vessel just stops. As opposed to this blood vessel, which continues on, gets smaller, sends off other little blood vessels, the same as this one here. This is a normal blood vessel. It gets smaller, sends off little branches, gets smaller, totally normal. But this one just stops. And that's why this person, the 77-year-old man, is having the problem, because there's no blood supply to this whole portion of his brain. This is what it looks like real time when we're actually taking the catheters up. So you can see this is one of the catheters here. That's the tip of the catheter. This is the wire that we have up in place. And this is us pushing the whole catheter and system up into the blood vessel that's blocked. Right here, we have a balloon in the person's neck, which is actually allowing us to stop flow into the brain, bring the catheters up easier, and eventually prevents the blood clot from breaking off and going further into the brain. And that's the catheter now coming into place. And right now, that's the site of the occlusion. That's the site of the occluded blood vessel right here. And that's where we'll leave the catheter. And then what we do is literally just hook it up to suction tubing, a big pump that causes a vacuum. And that's how we take the clot out. And this is what it looks like from the other side. Again, the balloon up in the person's neck. You see the catheters moving up along the wire. And this is what it looks like real time. This is real time us pushing the catheters up into the person's head. So we stop there. That's the catheter. It's engaged the blood clot now. And this is what it looks like when we're done. So you can see now this blood vessel, which previously stopped right there, is wide open. And this is what the normal angiogram looks like after we completely open the blood vessel up. And now, after the procedure, this patient woke up NIH stroke scale of 2. What that means, the initial NIH stroke scale was 17. What that means is basically he has minimal residual deficits. He had minimal weakness of his left arm and left leg, and that was it. Otherwise, he was neurologically doing phenomenally. So you can imagine that for a 77-year-old to not be able to move their arm and their leg, to not be able to eat or swallow, I mean, that person's going to need 24/7 care, and now he will go back to living a completely independent life. So that's why we take these things seriously, because we have the opportunity to help these patients. This was the clot that we extracted from the patient's head. This is what a blood clot looks like. We're measuring it here. It's about 2.5 centimeters. Stroke is treatable. Time is brain. And if you suspect somebody's having a stroke, then get them to a hospital because we could potentially do something about it. Now, just getting into a couple of the other kind of things that we do and treat just to kind of expose you to them. As I mentioned, we treat eye strokes. So the blood vessel that goes to the eye is what we call an end artery, meaning that there's no other blood vessels that can go to the eye. It's just that blood vessel. And if that blood vessel goes away, you can get single eye vision loss, complete vision loss. That's called a central retinal artery occlusion. The retinal artery is the artery that goes to the eye. So, central retinal artery occlusion is a blockage of that artery, which leads to monocular or single eye vision loss. You can see here, it's a very small artery. This is actually the central retinal artery seen on a specialized CAT scan. And it goes to the optic nerve and the eye. It causes immediate vision loss in the eye, and it's often associated with narrowing in the carotid artery. The diagnosis actually requires someone to get an ophthalmological exam or to be seen in a place that has one of these devices, which is called an eye scan or an OCT, which allows you to measure the retina and measure the blood supply and look at the retinal thickness and see if there's actually injury to the retina. And then once you confirm that, we can go into the actual small artery here and inject medicine to try and open that blood vessel up again. Not many places do this. I will give you just a sense of that. On Long Island, our hospital, North Shore University Hospital, is the only place that does it. I think in the city, Mount Sinai is the only place that routinely actually does this. The other thing we actually see a fair amount are nosebleeds, epistaxis. Nosebleeds can be a major issue. About 60% of people will experience nosebleeds through their lifetime, and 6% of cases won't be treated by pressure and packing alone, meaning they might require the ENT physicians to go in and cauterize a blood vessel or us to go in and block a blood vessel off. So what we can do is go into the arteries, which again, this is an angiogram here. So you can see a schematic of the nose and the arteries that go to the nose. And then you can see real time, this is what we see on an angiogram. Laser pointer back. This is what we see on an angiogram. So again, this is us injecting that contrast dye into the arteries that go to the nose. And you can see there's a lot of arteries that go to the nose. And we can go in and block off some of those arteries, and then we can stop the nosebleed. It's about 90% of effective in controlling the rate of bleeding, with about a 10% rate of rebleed after that. But these are patients who've already failed, multiple other interventions generally. So to be able to offer this treatment, which is about 90% effective, is relatively unique. And it's a relatively low risk treatment, frankly. Arteriovenous malformations and fistulas. So these are abnormal connections from the arteries to the brain. And I can show you, if anybody wants to see more of these, I have talks on these things, but these are certainly a neurosurgical challenge. In general, there's 3 ways to treat any fistula or arteriovenous malformation. You can do surgery, which involves taking them out or disconnecting them. You can do an embolization procedure. An embolization is where we go into the arteries and we block them off individually and try and block the blood supply to the lesion. Or we can do radiation. And the radiation we do is targeted radiosurgery. And that basically involves very, very high dose radiation to a very, very small area, which causes scarring of the lesion and then eventually blocks it off. The reasons why we take these things seriously is because AVMs have a rupture rate about 3.4% per year. And every time they rupture, they carry about a 40% rate of having some associated morbidity, significant morbidity. So it's not an insignificant risk of rupture. It's not an insignificant risk that something could hurt you. So we take these things very seriously as neurosurgeons. This is an example of a patient. I don't know if my videos are playing, but let's see. It's an example of a patient with an AVM. This is what it looks like on the angiogram. So this is what we did was you could see the patient's skull, their teeth, their eye sockets. This is a very large AVM in this person. This is us injecting dye into the carotid artery, which is what's feeding the AVM. And then I'm rotating the 3D reconstruction around so you get a sense of the size and how large this AVM is. I mean, it's basically taking up like 1/3 of this person's brain. So that was an AVM we treated successfully. This is what the CAT scan of that AVM looks like. Front of the head, back of the head. That's what an AVM looks like on imaging. So this was an AVM that we didn't treat with surgery because it's too large. But we treated with multiple sessions of embolization and then followed by radiation, and she was cured. Arteriovenous fistulas, these are very rare vascular lesions. They're, again, abnormal connections from the arteries and veins. They represent about 10 to 15% of all vascular intracranial abnormalities. This is an example of a fistula. Again, an angiogram here. We're injecting dye, and you'll have to take my word for it. What's happening here is the dye is connecting to the veins, and you're seeing the veins way too early when you should only be seeing arteries, because angiography it's an art, and it gives us time-based resolution of imaging, meaning we watch the contrast dye flow into the blood vessels and watch the contrast dye flow out of the blood vessels. And so we see the arteries, we see the capillaries, and we see the veins. And so that should follow the same order every time, right? But sometimes what happens is there are abnormal connections, and then you see an artery and a vein. And this is a vein right here, this large structure. So when we see an artery and a vein like this, we know that something abnormal is going on. In this case, it's a fistula. And this is us treating a fistula. So this is what someone's skull looks like after we fully treated the fistula. So this is a bunch of small metal coils, as well as some liquid, what we call liquid embolic agents, which are a type of glue. And now you can see us injecting the contrast dye, and you don't see that vein structure any longer. So there's no more shunting, essentially. So we know that it's cured. So arachnoid hemorrhage, major thing that we treat in cerebrovascular neurosurgery. The clinical presentation is usually someone's worst headache of life. 80% of the time, it's due to an aneurysm. And patients often have, multiple issues going on when they come in with the subarachnoid hemorrhage. This is what it looks like on a CAT scan. You can see this is the front of the head, this is the back of the head, this is the right side, this is the left side. And you can see just a little bit of white stuff where it shouldn't be in the brain. And that's what's called subarachnoid hemorrhage. In this case, it was due to this lesion here. So this is a CT angiogram, and this is a 3D reconstruction of that CT angiogram. So what you can see here is the blood vessel coming up and in, and then there's this big balloon off the blood vessel. Again, here, the blood vessel coming in, and then this big balloon off the blood vessel. That's called an aneurysm. So what we can go and do is actually go and treat that aneurysm. So we go either into the aneurysm with a small tube and put metal coils into it, or we can do surgery and put a clip right here at the base of the aneurysm and then block the aneurysm off. The way we decide that is basically, what we think is going to be best and safest for that individual patient. So for example, someone like myself, I'm dual trained. I can both clip and treat these patients endovascularly, meaning through the arteries in the leg, and treat them, through the groin. Similar to Dr. Langer, is also dual trained in that way. Neurovascular trauma. There's all types of neurovascular trauma. You can see here, you can get injury to the blood vessel, which causes kind of narrowing or ratty looking blood vessels, complete blockages, or then, like our other patient who we presented initially, complete injury and leaking of blood out of the blood vessel. That's obviously problematic. This is about the most severe type of neurovascular trauma that we'll ever kind of come across, essentially. And what we can do is we can go in and, again, put metal coils in to block off the bleeding. And then what you see here is this is what it looks like at first. And you basically can't see anything clearly because ultimately it's just all leaking from the carotid artery. And then afterwards, you kind of reform the carotid artery and reestablish normal blood supply to the brain. So just some take-home points. Basically, there are obviously numerous types of neurovascular emergencies we treat. We treat strokes, we treat bleeding, we treat eye strokes, we treat nosebleeds, everything. But in all these cases, kind of rapid and reliable assessment of their person's presentation is key. And understanding what's going on with these patients even before they come in the hospital can make the difference between excellent outcomes and life and death ultimately. So thank you guys very much. I practice mostly here at North Shore University Hospital as I do a little bit at Lenox, and this is us in the angiography suite. This is what it looks like when we do angiography, essentially. The patient's on the table here. You can see this is the screen we're looking at. You can see the image of the skull in the back here. This is the 3D reconstruction of the image, and this is us doing the procedure. So thank you very much, everyone.
Thank you so much, Dr. White. We did have a couple of questions, if you have time to answer
Oh
some.
yeah, of course. Sorry, I wasn't watching the chat. My apologies.
Worries at all. Somebody had asked, I guess this is a pretty basic question, but what is the reason that the arteries don't seem to be pulsating in the angiogram?
That's a great question. So that pulsation and that movement is very small. So if I were to actually show you an angiogram, you would see the blood pulsing forward, but the arteries themselves don't pulse very much. They do change a little bit. The artery wall is like a little bit elastic. And sometimes you can see small caliber changes, but in general, you don't see the arteries pulsing, but you see the blood pulsing and going forward. I don't know if I have a, I can look for an angiogram off the top of my head, but here, 1 second. I'm just gonna look one up. There's another question to it. Looks like a couple more.
Yeah, there's a couple more too as well. Do you want me to ask you while you're pulling that up?
We'll have an angiogram to show and scroll through. So this is, let me see what I can share. Actually, this has some patient information on it. So let me see if I have. I think I have a couple of runs here, a couple of videos here. Oh, wait, actually, I know to look up. Give me a second. All right. So this was a case that we did, and I think there are some angiographic runs in it. This is a 50-year-old who came in with basically arm and leg weakness over 2 months. This is a MRI of his cervical spine. These are the spinal levels here. Let me get the go back one. These are the spinal levels here. You can see that, sorry, it's giving me difficult time with the laser pointer. These are the spinal levels here. This is the base of his brain. This is the cerebellum. This is his spinal cord. And you can see this is what a normal spinal cord looks like in here. And here his spinal cord is all swollen, and it's a much brighter signal than above or below. So there's a lot of swelling in his spinal cord. This is what his MRI looks like. This is the MRI of his brain. Which is not loading very effectively, but I'll get to the angiogram. So this is what it looks like when you inject dye. So you see the contrast wash in. Go through the arteries, capillaries, into the veins, and then eventually leave. And I'll just show you for interest's sake. This was his issue. He had an abnormal connection from the arteries to the veins here, which is what was causing injury to his spinal cord. So we went and blocked that abnormal connection. I think I have it pre and post later in the talk. This is that abnormal connection. It's right here on the inside of the skull. The red is all his blood vessels. The white is obviously his skull. That's the abnormal connection. So we put a small catheter. This is an injection through that catheter. That's the abnormal connection there. And then we injected a type of glue, essentially. And that's what the glue cast looks like at the end. But yeah, so that's what the blood looks like when it flows through. And this was an example of, us injecting glue to block this little connection off. And then after the procedure's done, you see that that connection's not there anymore. And he improved significantly after the procedure. Yeah. When do you consider TPA over percutaneous solution? So there's a lot of this is like very well studied when to do TPA, when to do thrombectomy. They don't exclude each other. If you give someone TPA or TNK, you could still do thrombectomies, just so you know. The issue with TPA or TNK in the United States, we can only give it up to about or they're not only willing to give it up to about 4.5 hours. In a few countries throughout the world, they'll extend that window because there's pretty good data and evidence and literature that suggests that if you select patients based on their imaging finding, you can give TPA, up to 12 hours out, potentially even longer. But if someone gets TPA, it doesn't mean they're not a candidate for a thrombectomy. You can still get a thrombectomy. But thrombectomy candidates have relatively strict guidelines in terms of like who's actually a candidate or not. And it's basically, do we think we're going to help them by taking the blood clot out? So can we get there safely? Can we get the clot out? And do they have brain that we can actually help? Can you elaborate on the factors and diagnostics you use to decide if they're a surgical candidate or not? Can I just ask Robert Waxman, when you say surgical candidate, was that with regards to aneurysms based on the timing of the talk? Or something else? Okay, aneurysms. So that's a great question. Back in the early 2000s, there was a clinical trial called ISAT, the International Study of Aneurysmal Subarachnoid Hemorrhage, and its treatment. So it enrolled 2,100 and I think 43 patients, and it randomized them. If you had a ruptured aneurysm, and again, this is 25 years ago, did you get treated with surgical clipping or endovascular coiling? And what that trial showed very convincingly is that endovascular coiling, for the most part, was safer than surgical clipping. So they looked at those patients, they randomized them to treatment, and then they followed those patients up and saw how they did clinically. And you did clinically better if you had an endovascular procedure. There was a trial that followed that up because that was mostly in Europe, and there were a bunch of American neurosurgeons who didn't like that trial. The trial that followed that up was called BRAT, the Barrow Ruptured Aneurysm Trial, and it found essentially the exact same thing. The bottom line, if there's equipoise for an aneurysm, meaning it could be treated with coiling or could be treated with clipping, it should be treated with coiling because that's safer and the patients do better. The only downside to endovascular treatment is it's not as durable as clipping. So the chance of recurrence of clipping is like single digits, 2-3% probably. The chances of recurrence with coiling is 5-10%, basically. So there's a little bit higher risk of recurrence, but it's a less invasive treatment. So it's generally considered to be safer. That being said, not all aneurysms are amenable to both. So there are certain aneurysms that should be clipped, and there are certain aneurysms that should be coiled, and that just has to do on their individual anatomy. But for the vast majority of aneurysms we see, most places are coiling most aneurysms because the data is very clear that coiling is safer than clipping. That makes sense? It's a good answer.
Yes. There are a couple more questions. Somebody had asked if someone is born with an AVM, how is it managed and at what point is surgery considered for that person?
That's a great question. So we think that AVMs are congenital lesions. So we think that people are born with some degree of some sort of AVM if they're found to have an AVM at some point in life. Um, that being said, there are different types of AVMs. Uh, in general, once they become symptomatic, most people will treat them in some way, shape, or form if they're amenable to treatment. If they're totally asymptomatic, it becomes a conversation with the individual person and the individual patient. And there's a little bit of um, an open conversation in terms of what the best management of AVMs are. There was a very poorly done clinical trial which talked about randomizing patients to AVM treatment versus no treatment, except that the methodology and design was completely flawed. So it had a conclusion, which was that it's safer to observe AVMs than it is to treat AVMs. But based on the data it collected and the patients it's included, you could not make those conclusions. It was basically a completely inappropriate clinical trial, essentially. Um, so ultimately, we don't have good data on what to do for AVMs. We just know that they carry about a 3.4%. It's basically 3 to 4% risk of rupture per year. So every AVM really has to be managed individually, and it has to be a conversation with the individual patient. How do they want to kind of take their risk, and how do they want to deal with their AVM? You'll see most neurosurgeons are relatively more aggressive when it comes to treating AVMs. And what I mean by that is if they're amenable to treatment, we recommend they should be treated, because instead of it being a lifelong problem, if they're amenable to treatment and we can take care of it, we think that's usually better for the person than leaving it be a lifelong problem. But it is really an individual conversation and consideration.
Yeah, that makes sense. Thank you. There is another question. Are there any steps you can take to prevent an SAH from occurring in a patient that likely has a Berry aneurysm?
That's a great question. There are some what we call modifiable risk factors associated with aneurysms. So whenever we talk about medicine, we talk about risk factors. In medicine, when we talk about risk factors, there are modifiable risk factors and there are non-modifiable risk factors. So non-modifiable risk factors are like, what are your genetics? We can't modify your genetics, right? So some things we can't modify. But for Berry aneurysms, there are some modifiable risk factors. The biggest modifiable risk factors is number one is high blood pressure. Number two is smoking. So avoiding smoking and controlling your blood pressure, and then just in general, healthy lifestyle are probably the most important things, or the only known risk factor things that we can do. And then obviously monitoring the aneurysm, because if the aneurysm is ever seen to grow on imaging, then it should be treated because aneurysm growth is associated with about a 10 to 12% increased risk of rupture compared to a non growing aneurysm. So that's why we as neurosurgeons will monitor aneurysms over time.
There's another question about if a patient were to have a condition such as polycystic kidney disease or similar, how likely would they be to have an aneurysm?